Hi, my name is Jason Young. I serve as the chief for the Division of Pain Medicine at Brigham and Women's Hospital. And I also serve as the medical director for the Pain Management Center at Brigham and Women's Hospital. Today, I'll be talking about cancer pain and going even beyond the pump and what some of the new treatments for cancer pain might be. A few of my disclosures: I serve as a consultant for Medtronic, who manufactures some of the things for pump treat or for cancer pain. Also serve as a consultant for Nevro, Abbott, Boston Scientific, and Biotronic, and then do some sponsored research with these companies as well. The American artist Georgia O'Keeffe had once said that I found I could say things with color and shapes that I couldn't say any other way, things I had no words for. And collage, Collage, was founded in 2006 by Dr. Jennifer Weller at MD Anderson. And her goal was to use art so that patients with cancer could express themselves and say what they needed to if they didn't have words for it. So her goal was to bring art to cancer patients, promote creativity, wellness, and relieve some stress through that self expression. They've had more than 4,000 patients, family members participate in programs and have had amazing art. So, a lot of the graphics from the presentation will be generated from the Collage Art for Cancer Network. The agenda of what we'll be talking about is some of the background for cancer pain, because I think it is important to understand why we get cancer pain and where it comes from, and some of the traditional interventions. And then we'll talk about these other things that go beyond traditional interventions: regenerative medicine, neuromodulation, and then even other therapies as well. So, in terms of prevalence of cancer pain, 1.8 million new cancer diagnoses and over 600,000 cancer related deaths in the United States in 2020. So, this is incredibly, incredibly prevalent and impactful, and we all have had people affected. My mother passed away from lung cancer. 80% of advanced cancer pain patients experience moderate to severe pain. And so it is something that is incredibly impactful to the patients suffering with cancer pain. And then 62% of cancer patients presenting to the emergency department presented primarily for pain as their primary problem. 55% of those patients reported significant pain from their cancer therapies, and that might be from the radiation, the chemotherapy, the hormone therapies. So not just the primary pain from the cancer itself, but also the treatment of the cancer. We have a lot of interventional treatments that we will try to offer patients, and they are effective in providing pain relief. And the palliative care people have done great studies to show that if we are able to help pain relief, then we can reduce the burden of symptoms, minimize opioid intake, and have lower complication rates, improve their quality of life, improve their time remaining with their families so that they can have more meaningful interactions from a palliative standpoint. In terms of head and neck cancer, that is something where pain is by far the most common complaint in patients with head and neck cancer, because the face, the head and neck are so innervated. 81% have it during therapy because a lot of radiation with head and neck surgery. You have 70% even at the end of therapy continue with pain, and that 36% even at 6 months after treatment continue with pain. And so this is not just the time of getting the treatment, but also beyond that and the healing process. So it can become chronic even after the treatment for head and neck cancer. Switching to lung cancer, this is a similar thing where you have complexity and a lot of innervation, but then also you have bones and you have the pleura, so it's visceral as well, and then a lot of radiation as well. And with the chemotherapy, now they have immunotherapy, so maybe hopefully less, but still, even with the chemotherapy, you have patients that have pain from those therapies. The 5-year survival post diagnosis for lung cancer is about 15%. The majority will die within a year, and the pain prevalence is about 50% of patients will have it. Breast cancer, this can metastasize to any organ, so the prevalence of pain when you have the metastases is very high. Um, and people are surviving longer with these cancers because of the innovations in cancer treatment, but the pain may still persist beyond the actual burden of the cancer itself. With breast cancer, if it was surgical, you also have decently high rates of post mastectomy syndromes, and so pain after a mastectomy. In terms of pain in the abdomen and pelvis, also very complex. This is a lot of visceral pain that you might be experiencing, and then pain while you're undergoing treatment as well. The abdomen and pelvis is extremely complex and lots of different areas of involvement that you can get with carcinomatosis or just metastases that go to different organs. The primary thing that we see at our institution is the pancreatic cancer patients that deal with abdominal pain, but we see it in all other solid organ cancers as well. So we talked a little bit about this, but the direct and indirect courses of how you can get pain, and then even the surgical part of it or the chemo and the radiation can have it. One thing that is not highlighted enough in our educational system is the amount of patients that are dealing with pre-existing pain conditions. So people with low back pain but then got cancer, or post-laminectomy syndrome and then got cancer, and they're dealing with chronic pain syndromes on top of their cancer, just kind of gets lumped into this cancer pain bucket. And you have to really consider the psychological aspects or impact that cancer can have in augmenting some of the pain as well. So that affective amplification of pain can be there because, as you would imagine, there's significant psychological impact that a diagnosis of cancer can have on patients, and that can augment the pain. In terms of the characteristics, the pain will change over time, and it will involve multiple sites and likely arises from several different origins. So you have the nociceptive part, the neuropathic part, and one thing that we try to tease out as much as possible is that difference between the baseline and the breakthrough pain. As we are teasing that out, are we seeing the pain is primarily being well treated from that baseline, but then the spikes of pain are just not controlled, and they're having to go through a lot more of the breakthrough medication than they think? Well, that's what we're going to target. That's where some of the interventions may or may not be beneficial as well. Pain worse at night, and just knowing the circadian differences in the pain manifestation. And then looking at if you have a patient who has been stable on a regimen, but then there's a sudden increase or spike in the pain, to have that ding as a red flag, and that you might need to investigate further to see if there's any relation to increased burden of cancer at all. The next part we'll talk about is the traditional interventions that we do for pain. The types of interventions that we do are going to be split into single interventions and then continuous interventions. The majority of the things that we have are the single interventions. So that's exactly what we do in pain medicine, right? We have the nerve blocks, we have the um, plexus, the somatic nerves that we're targeting. We have local anesthetics versus steroids. We have alcohol ablation or phenol ablation. We have radiofrequency lesioning. And then we have single interventions in terms of procedures that we can do, like kyphoplasties or vertebroplasties. And so this is where we will often be consulted for a specific indication for a specific intervention. When we think about the different nerve blocks, we try to think about them in terms of diagnostic and therapeutic, but then there's also a little bit of a prognostic indicator in there and looking to see how the patient would potentially do with some of these therapies here. In terms of the neurolytic blocks, we have the ability to destroy some of those nerves or scramble, modulate, however you want to describe it. And there are cryotherapies, radiofrequency lesion, gamma knife therapy, and then there's chemical neurolysis. And so when you have alcohol, there's a phenol shortage, so we've been using alcohol, but the boards used to harp on the difference between alcohol and phenol, especially if you're thinking about doing it intrathecally. If you're doing it intrathecally, alcohol is hypobaric and phenol is hyperbaric. And I just kind of think about mixing drinks, and you see if you put the alcohol first and then your mixer, you have a good cocktail. But if you do the mixer first and then the alcohol, then your first sip is just pure alcohol. And so it is hypobaric. And so how you position the patient after an intrathecal dose of chemical neurolysis will differ if it's alcohol versus phenol. Do you put the non-dependent side up, the dependent side, T-Berg, reverse T-Berg? And so those are the indications that go into that. Alcohol burns, like when you put it on a cut, and phenol is actually a local anesthetic as well, so it should be non-painful. And with both of them, you will get some neural regeneration. In terms of targets for our autonomic nervous system, so it's if you look on the spine and that lateral view of the spine, it's all the same chain. It's just the part of the chain that you're trying to go for, right? And so we know that our preganglionic chain or parasympathetic chain runs up along the anterior one third of our vertebral bodies, along the lateral aspects of them. But which level you're looking at will dictate what the name of it is. And so when we look at C6-7, that's our stellate ganglion. And so that's where we're targeting chest, signax, tubercle. We're getting the face, we get the Horner's, upper extremity for CRPS. Even long COVID now, we're doing this for autonomic dysfunctions, PTSD, some of the cardiac supraventricular tachycardias, exercise intolerances that are autonomically mediated as well. That's where we're targeting the stellate ganglion, around C6. As we go lower down, the T11, T12 part of the chain wraps around to the front and combines and goes a little bit lower to in front of L1, but they wrap around to combine into one plexus called the celiac plexus. And that's what gives us sympathetic innervation to our upper GI tract, our stomach, our liver, our pancreas. And that's where we would target either a celiac plexus block or splanchnic nerve blocks if you're doing unilateral or you're looking to do an ablation with radiofrequency. Our hypogastric, we get it closer to L5. And that's where we'll see sympathetic innervation to our pelvic viscera, our bladder, our uterus, our prostate, and then our distal colon as well. And then the last spot we go to is not quite super analogous because it's just anterior to the sacrococcygeal ligaments, but it's still a similar plexus that we're trying to block. But this one is for our ganglion implar, and that's where we get our distal GI and our rectum. So here you see all the different plexes that we can block, plexi, and the different innervations of the organs. Aspen came out with the first author, Mansour, who is absolutely amazing, and created a best practice guideline. They dissected the entire literature and created an amazing resource here for cancer-related pain. So this is in 2021. And I urge you all to take a look at it and see it. It is incredibly well done. and offers the best evidence recommendations for utilizing advanced interventional therapies in cancer pain patients. Here is a sample of it in the table 7, where you see some of the best practices. And you see opioids, for example, for cancer pain, and the level of evidence and the grade. And then we see some of these things that we typically do with the blocks, right? The targeted drug delivery, the spinal cord stimulation. So things that we'll be talking about with this, but this will break down a lot of the data that goes into this presentation. And they did a wonderful job, in my opinion, with the breakdown of the data here. Now we went from single interventions to now talking about the continuous interventions, that continuous delivery of medications. And that's done through intrathecal therapy. And so we have a lot of different ways of getting that medication, either neuraxially, but either intrathecally, typically intrathecally, but sometimes epidurally, especially in a palliative way or a hospice way. We might just do a continuous epidural infusion of medications. But in terms of intrathecal medications, we have a lot of different off-label indications for it. So the on-label indications for intrathecal drug delivery are going to be your Duromorph or morphine, Gabapentin or Baclofen, and Prialt or Ziconotide, which is the calcium channel blocker derivative of snail venom that's for neuropathic pain. But some of the off-label medications that we can do for this include different types of opioids that are non-FDA approved, off-label. Local anesthetics, usually bupivacaine is what we will add for that. Alpha agonists like clonidine or GABA agonists like baclofen. So lots of different things that we can do. And then some of the things that we'll be talking about later in other will be some of these novel therapeutics that we can potentially introduce into the intrathecal space. Now, where do we place the catheter? Well, it depends on the pain location. And in 2017, the PAC guidelines recommended placing the tip around the spinal dermatome that was associated with the majority of the source of pain. And that's what I typically will do as well. The recent publications provided level specific bupivacaine dose recommendations as well as the area to put it. And that can be a little bit tricky because bupivacaine as a local anesthetic can cause a sympathectomy, and it may be something you have to be a little bit wary of. And then sacral or pelvic pain can also be a little bit tricky. You can either put it right at the vertebral body, like the level of the conus, like they mentioned here, or you can think about doing retrograde and going down with the catheter tip and entering L4-5 and getting a catheter to go down as low as possible there. Now, in terms of the regenerative piece of it, this is interesting because regenerative medicine is a burgeoning field in pain medicine. But then when you apply it to cancer pain, it's even more burgeoning and more studies need to be done. And so the evidence of using stem cells and platelet-rich plasma in managing cancer-related pain is still emerging. And there's some promising findings, but limited if you don't have that robust clinical data. In terms of the mesenchymal stem cells or the stem cells, that has shown some potential in preclinical studies for managing cancer-related pain. One example is a study that demonstrated adipose-derived stem cells can reduce pain in rat models when you have chemotherapy-induced neuropathies. And it's thought to be likely through the modulation of the VEGF pathways. Additionally, the bone marrow-derived stem cells have been found to produce analgesic effects in animal models of cancer pain as well, and that's potentially through the anti-inflammatory mechanisms and modulation of neuroinflammation there. In terms of the PRP investigations for analgesic properties in various pain conditions are there, and that's for neuropathic pain, but that can be tied in or walked over to cancer-related pain as well. A systematic review found that PRP injections could improve pain intensity in neuropathic pain conditions, but those studies were not necessarily specific to cancer pain, but we could draw that conclusion or that parallel very clearly with that, as it makes a lot of sense. One thing that's extremely promising is this regenerative medicine piece of it with Schwann cells. And so this was a publication that came out in 2023 looking at Schwann cells. And Schwann cells act as a small biologically active pump that can secrete pain relieving neuroactive substances. And these Schwann cells can help regulate the progression of tumor cells, and it can include that proliferation and metastases. And through the neurotumor crosstalk is is critical in the role of Schwann cells in modulating some of that cancer and also cancer related pain. The mechanisms in which Schwann cells repair the injured nerves and exert the analgesia include some of the neuroprotection, neurotrophy, nerve regeneration, neuromodulation, and immunomodulation, as well as the enhancements of the nerve injury microenvironment there. And so, a lot of promise with this, and a lot of research to hopefully be done in the future to see if this will help not only with the cancer propagation, but then also potentially just the pain related to cancer. Neuromodulation is a field that we talk a lot about because of pain, but the application for cancer related pain is not as mature as it is for other pain syndromes. The neuromodulation for cancer pain we break down into peripheral nerve stimulators and spinal cord stimulators. In terms of the peripheral nerve stimulators, basically any named nerve can be targeted and modulated with peripheral stimulation. And there are temporary peripheral stimulators that can come out of the skin. There are peripheral stimulators that can have an external generator, or you can use a traditional array and implantable generator that goes like you would with a spinal cord stimulator. And so, in terms of spinal cord stimulation, very similar, 2 to 4 leads, 8 to 32 contacts that you can place in the epidural space. And that can be usually with an implanted battery, but there are also spinal cord stimulation adjuncts that you can do where you have an external battery source. And the cancer related pain indication for spinal cord stimulation or for peripheral nerve stimulation is still novel, but Medicare is approving it for some of these refractory cancer pain patients. A lot more data to be coming out with this, and a lot of data and a lot of studies to be conducted. One of the studies was from Sloan Kettering, where they looked at 51 patients over 18 years. And these were all patients with cancer dependent pain. They had analyzed this and had some control with the non-cancer dependent pain patients. And they found that these were patients that were typically refractory to traditional therapies. So all the things that we had talked about in the earlier part of the talk. And even though they've continued maximizing that and trying all of that, the patients that had the spinal cord stimulation showed a 23% reduction in their pain. And it was an extremely viable option for those who had failed conservative therapies. Interestingly, the opioid use did not dramatically decrease, but these, again, are cancer pain patients. So the indications and the origin of the pain can be very different for these patients. And that is not out of the realm of expectation for what you would think. In terms of that viability of doing it for cancer pain patients, I think if we can continue to push insurances to allow us to just provide quality of life for the patients, and especially for the ones that have cancer-related pain from chemotherapy or from radiation and are in remission, then that's a very good indication. It's neuropathic in nature typically, and it's something where the patient typically has a longer duration of life expectancy, so that it would financially be more reasonable to consider spinal cord stimulation. But I think the economics of just having decreased burden of health in terms of ED visits and other interventions that we have to do should justify it as well. And the last part of the talk will talk about some of these new directions that we can be heading towards. In these new directions, there are high intensity focused ultrasound. So the ultrasound innovation is booming as well as the neuromodulation part of it. And with some of these adjuncts with ultrasound, they can focus the energy in different areas, and that can have a profound impact on pain relief as well. The radio frequency ablations, so not just our traditional targets, but even thinking about non traditional targets. One example would be the osteocool for patients with vertebral compression fractures that are related to cancer. That ablation is there, but then it goes even beyond that to different targets of nerves that we're trying to get for innervating different areas of pain. And very similar to the chronic pain conditions that we are innovating on RF ablation for. There are a lot of cancer-related pain diagnoses that can be in that same boat there. In terms of biologics, monoclonal antibodies, there are a lot of different indications that we have for our innovations that we have for being able to help to treat the pain, but also the cancer itself. And so a lot of research being done with that as well. One of the interesting things would be the trip V1 and giving it intrathecally. We've given it intra-articularly for some of these knee patients, and it can burn quite a bit, but can help pretty profoundly with a lot of their pain. And there is research being done on being able to deliver that intrathecally. So intrathecal drug delivery is something that we have a lot of experience with, but now we have the ability to potentially innovate based off of that and to provide other medications and other therapeutics that we can put into that. And there are also studies that are being done for intrathecal drug delivery for treatment of some of these neuroprogressive diseases, but then also potentially cancer as well. So thank you for your attention on going through the background, traditional interventions, regenerative medicine, neuromodulation, and some of these other novel therapeutics for cancer pain, going beyond the pump there. And I'll leave you with a few take-home messages. I think it is an extremely super exciting time to be in pain medicine. The amount of research and innovation and novelty that we have to be able to treat patients is booming. And we are innovating on the biologics, the technology, different protocols. What we're going to see is over the next decade, many more will come, a lot of breakthroughs. And one of the kind of most important things when we're dealing with cancer pain is we really have no holds bar. We want to do everything and anything possible to try to help optimize these patients because we want to try to improve their quality of life, improve the amount of time or the quality of time that they have remaining with their family members and their loved ones. And as we see it all affecting everyone, we're, I think, drawn a little bit more to the patients that are dealing with cancer pain. And so, thank you for your time and attention. I hope this was helpful. And again, I'm excited about pain, and I hope there will be many, many more innovations, indications, and therapies to be done in the future here. So, thank you.